I would like to invite Dr. DEBDULAL first. He would be talking about the real world data on biosimilars. Dr. DEBDULAL, please.
Thank you so much, Dr. Ashish, my very good friend, and it's a pleasure to be here with him, and also Sir Mangadogra Sir, our teacher, and my regards to him, and Sir, you too, and also Dr. Nilesh and Dr. Nikula and Dr. Satyaprakash, and I'm really thankful to be part of this team. And Dr. Ashish is someone that I always look forward to as far as anti-VEGFs go as a whole, and because he has his own long-standing association with anti-VEGFs, and all of us have learned a lot on how to use anti-VEGFs. So basically I'll be speaking on our experience with biosimilars. So my disclosures. So basically we'll be dividing this into three parts: need for biosimilar anti-VEGFs, safety of biosimilar anti-VEGFs, and efficacy of biosimilar anti-VEGFs, and we'll talk about these as we go along. So today, there's absolutely no doubt that anti-VEGFs are necessary if you are to treat retinal vascular disease, and there's ample data that shows that there's been a lot of reduction of blindness, so to say, due to retinal vascular disease once the anti-VEGFs came along. However, treatment may be relatively expensive with biologics, and this can restrict patient access and treatment lengths, leading to suboptimal clinical outcomes. And this is important not only for our country and the developing world, but also in the developed world, where they are now increasingly looking into biosimilars. So a part of the problem is a significant unmet need exists in many of the patients with retinal vascular diseases, one of them being unresolved fluid. So you need to go on and on with the injections. It's not a one-off game. And you have to have patients having to agree with repeated injections, because unless there are repeated injections that are possible, it's not possible to treat retinal vascular disease. But the problem is, if you have look at the luminous data, which is probably one of the largest data that we have on usage of anti-VEGFs. So if you can see here, half of these patients actually have maybe 3 or 4 injections at the most, and if you combine 5 injections, that then adds up to 60%. So, and this is something that's not good enough, because if you are to treat, say for example, diabetic macular edema, and provide some gains to the patient, then you need to have somewhere between 5 and 7 injections, which is a rarity in our country actually with patients. And similar is the incidence are the results with neovascular AMD. You need to have really at least maybe 5, 6 or more injections to actually have some tangible results. Now, in the Indian context, what is probably very, very important is non-affordability to the biologics which are there in the market. And this is where I compliment the biosimilars to start with, of course, the Intus company for providing something made in India for the Indians and also for the developing world and beyond. So, and at this point in time, it's very important to actually, talk about this important publication that has come up in the American Journal of Ophthalmology just a little while back by my friend, Dr. Ashish and his group. And what he goes on to say in a nutshell is, biosimilars hold the potential to reduce the financial burden of highly efficacious biologic therapy in retinal pathologies. And this is something that's going to, get better with time. So what's holding us back from using biosimilars? Well, this is again something that he has spoken on, and in the eye there was this very important publication that came up. So this is because of the widely popular perception that biosimilars being generic versions of innovator molecules. I'm quoting Dr. Ashish, and that brings a nocebo effect, that is negative perception amongst the care providers and the patients. So this is something that actually needs to be dealt with. This needs to be done away with. Now, to dispel the doubts, let's check on the safety and efficacy of biosimilar ranibizumab. Now, at this point in time, I should tell you that at Disha, our biosimilar experience is mostly confined to Razumab, and this is something that we've used for more than 25,000 procedures. And of course, as you know, Razumab has been used over the world for more than 5,000 procedures as of now. So let's talk about safety, because safety of a biosimilar is something that we look into right from the word go. And I'm happy to share this with you. We actually have the largest data as of date for biosimilars, as far as, the safety of biosimilars goes. And this is 9406 Resumab procedures that were performed on 6404 eyes. And what we saw was that with Resumab, the adverse events seen were around 21%, but 97% of these were non-serious adverse events. And these adverse events were not very different from what was seen with the innovator molecules. Also, our large sample size detected a very minimal endophthalmitis rate of 0.01%, which is in keeping with other published literature from some of the better places. So to conclude, in a real-world setting, intravitreal Resumab therapy has an acceptable ocular and systemic safety profile in management of chorioretinal vascular disease. So this is our publication, so I'm going to beat my drum, but let's look at what others have to say. And the pioneer in the field, Dr. Ashish Sharma, says that no alarming immunogenicity with Resumab was noted, and this is something that he has published in the eye. So, there's, hardly any doubt today amongst us users, and also beyond that, there's Resumab is something safe. The president of AIOS, Lalit Verma sir, our teacher, has also, published on this, and he has, shown that Resumab is safe and effective in the short term in DME, NAMD, and also RVOs. So we'll like to move on to the next publication that we had. This is on DME, and if you notice here something very interesting, right from the word go, from month one, you have a statistically significant improvement in the vision as far as both innovator and biosimilar ranibizumab, Resumab here to be precise, goes, and this actually lasts out and right up to month 12, and there's hardly any difference between the two drugs, the innovator molecule and Resumab, or the biosimilar molecule. So all along the way, this is something that's working just like the innovator molecule. And as far as the central subfield thickness or the central macular thickness goes, again you can see there's a dip, and once the loading dose is done, there's a significant dip in the CMT values, and this is how it lasts out throughout the year if the patient is compliant.
DEBDULAL, just to interrupt, sorry to interrupt, just go on the previous slide.
Yeah.
Sorry to interrupt you, but just keep this slide in my mind, because this is a very important slide. Although this is his real world data, but this is a very important slide from regulatory perspective. So if you really look at this 1 month and 2 months, that's where if you see, both the drugs, they converge. One is the innovator molecule and another is a biosimilar molecule. So the kind of effect that you see in 1 month and 2 months, that means at 4 weeks and 8 weeks. So that is a sweet spot for all the biosimilars when the primary endpoint is placed. So because always there is a question that, these trials are very short, primary endpoints are very short in these drugs, how do we believe them? But here, this is the reason, as he also rightly pointed out, that maximum effect that you see from these drugs comes around 4 weeks till 12 weeks. If you see, then there's a plateau. So you cannot really judge the equivalence if you have your endpoints later. So that's the reason, rather than, thinking that, because the trials were short. So just sorry to interrupt, but it was a beautiful slide.
I think this is something that's very, very important you pointed out. And I think, this is why I actually, ask him for his articles as they come out, because, his is an experience, his is an bird's eye view of the whole scenario that he's been sharing with us for all this time, and this is something that's very important, and we learn each day with each publication that he comes out with. So regarding safety, and efficacy in DME, there's hardly anything to choose between the innovator molecule and Resumab or the biosimilar molecule. So moving on to the next publication that we had just a month back. This is the BALANCE trial. This is on neovascular AMD, comparing the innovator molecule of ranibizumab with biosimilar, that is Resumab here. And as you can see, again from this is the best corrected visual acuity. IRM stands for the innovator molecule, BRM for the biosimilar molecule, Resumab in this case. And as you can see, the visual acuity performance is pretty much similar, and right from month 3 after the loading dose, you get a substantial improvement in vision, which is statistically significant, and there's hardly any difference between both the visual acuity and the central subfield thickness in both these groups. There's an improvement at 3 months, which is just what he was pointing out for the DME article also. And this is something that lasts out, and this is something that you can drive with biosimilars, because the patients are more willing to kind of invest in this biosimilar, which is relatively less expensive. Now, intraretinal fluid and subretinal fluid, we keep talking about fluids in retinal vascular disease, and this is something that the patients had a similar response to with both the drugs. And more importantly, do you need more biosimilars than the innovator molecule when you treat a patient in these groups? Well, not really, because the numbers required were pretty much the same in both groups, and there was no statistically significant difference. And of course, the adverse events profile was pretty much similar. So intravitreal injection of innovator and biosimilar ranibizumab shows similar efficacy and safety in Indian eyes with NAMD. And I think it's time that all of us need to change and need to believe that things produced in India can be as good as any in the world. Thank you so much.